Good morning, everyone. Respected faculty, respected faculties, and my dear colleagues. I am Swara Bhatt in the Department of ENT and Head and Neck Surgery of the Pramukh Swami Medical College. Welcomes you all to this live surgical demonstration of temporal bone dissection. We have with us the great academician and the excellent ENT surgeon, Dr. Shabbir Indorewala sir. He is right now managing director and the chief consultant at Indorewala ENT Institute, which is well known as the center of excellence for the otology and the lateral skull base surgeries. He is recipient of the Ralph Cooper Award and the AOI Merck Award, the Gaurav Patra Award by the Association of Otorhinolaryngologists in Indian Nasik branch, and numerous other awards. He is known in his original research work for the dimensional stability of the free fascia graft, which included the animal experiments. The research have been published in the Laryngoscope journal and was invited for the presentation for the first International Fascia Research Foundation at Harvard University. I thank you all for being here and I wish you all a productive and enriching experience at this live demonstration of the temporal bone dissection session. Let's make the most of this, let's make the most of today and let's begin with the temporal bone dissection with Dr. Shabbir Indorewala sir. Without wasting much time, I would like to call sir for the temporal bone dissection live demonstration today. Thank you.
Hello, hello. We are a very small crowd, so we really don't need mic, and cannot be a formal topic. We can all talk out whatever we want, whatever you want me to talk about. Feel free. There is no question at all in this world which is stupid. The answers can be stupid. So you don't hesitate even if you have the stupidest of question that you think is stupid. It's not stupid. And if you have a question, if you don't ask, you remain lifelong ignorant. If you ask, you remain ignorant for a minute only. So just don't hesitate. There is nothing like मैं कैसे पूछूं मुझे तो डर लगता है. I'm particularly telling you to the juniors, Don't ever hesitate. कितना भी बड़ा क्राउड है, तुम कहीं भी हो, नहीं समझा तो नहीं समझा, नहीं समझे क्या कर सकते? So ask. The fellow may answer very stupidly is another matter. That's not your concern. So with that as a preamble, એ લોકો પેલા soft tissue કાઢે ત્યાર સુધી we can talk. Now, few things about temporal bone dissection. One, you must do. Keep doing it lifelong. If I have become good in otology, it's thanks to this temporal bone. One, and thanks to all the delegates who have attended my workshop, because they end up teaching me a lot. Every time you do a temporal bone dissection, believe me, you learn something. Every time, even now when I do a temporal bone dissection, I learn. I end up learning something new. अरे ये ऐसा दिखता है, अरे ये ऐसा होता है. The variations, the possibilities that you keep on, your three-dimensional image of the temporal bone becomes more and more clear. So मैंने 2 temporal bone dissection किए हैं, it doesn't help me. मैंने 50 किए हैं, it doesn't help me. Continue doing it. It's a lifelong process. Believe me, I mean, take all my words as they are, because I'm talking from within, मैं जो सीखूँ छे तमने बताऊँ छूँ. There are no frills attached to whatever I'm talking. Now, when you do temporal bone dissection, there are few things is, anything is bendable or adjustable except your back. Your back will not bend. You will not sit like that and work. Neither will you examine your patient bending, nor will you write anything bending. Your back is straight always. You only bend your back when you are examining an elderly person. It's the only time you are allowed to bend your back. Otherwise, your back remains straight. The microscope is adjustable. The table, the operation table, or the table on which the temporal bone is kept is adjustable. Your stool is adjustable. You have a variable, angulated eyepieces which are sometimes adjustable. આમાં નથી, and hoy na hoy, everything else you adjust except your back. Keep it in mind. If you want to really go on working for 50, 60, 70 years, you will not bend your back. If you want to work for 20 years and then call yourself as Kaka, then do it. You'll become very easily an elderly old person. There's a small other thing is, do exercises. Do it daily. You don't want to become, those He-Man and all that. It's not that. But 15 minutes pan exercise kari lidhi. And it may not be very heavy exercises, but do it. Make it as a part of your life. It helps you a lot. It helps you a lot. If I am well in my health today, it's thanks to these 2-3 basic things that I have done all my life. My teacher told me that. I remember Dr. M.G. Tapan. He would always say, don't bend your back. कुछ भी कर लो, back को bend नहीं करने का. I'm just passing it over to you. When you do temporal bone dissection, keep temporal bone in its normal, natural anatomy. Don't pick it up and start drilling. It's not carving that you are doing. You are doing a practice for surgery. So the temporal bone has to be kept in its way it presents to you in a live person. That means the head turned to the other side. You are sitting behind and then doing it. And now with respect to microscope, again, you must see to it that your IPD, interpupillary distance, is well adjusted on the microscope. You can do the surgery with specs on or without specs on, it does not really matter. Only in certain cases it matters a lot. And it matters, immensely. That means if you have a very high cylindrical number, 0.5 cylinder here and there does not really matter. But if you have 1, 2 or anything more than in that range, then it matters cylindrical number, because there are no cylindrical lenses in the microscope. So the only way you can adjust is to wear your special cylinder. Now it's those axes also. So if you have cylindrical number, any one of you, you will never see under the microscope without your specs. And if you have spherical number, it does not matter because there are ways of adjusting it. Just bring the microscope up and down, and what is focusing for me here is focusing for you over there, if both eyes are equal. If both eyes are not equal, you still have objective adjustment on which you can adjust it, but the same thing with the same, without moving the microscope, with the right eye and left eye, you should be able to see it in focus. So if you have different number, hypothetical +1 and -2, I mean whatever the numbers are, but they are different. What I want to know or tell you is that if they are different, then you adjust it in such a way that with both eyes you are seeing the same object without moving the microscope in focus. Ekdam much basic I am talking ridiculously basic, but I have seen seniors 10 years, 15 years doing surgery in a ridiculously bad way in unadjusted microscopes. That means they have been using their one eye all their life, and they use Zeiss microscope. A microscope cannot be improved. You can improve a lot. Now, if I keep my hand like that, I think I can show you that. You continue, you continue, you continue. અહીંયા જોવાય છે પણ કદાચ તમને નહીં જોવાય. You see two spots of light on your hand if you keep your hand. It's the reflected beam which is coming. Now these are called as exit beams or exit light. Now if I am looking in the microscope, the exit beam should go into my pupil. So from outside you cannot see light. If Dr. Mishra is operating and looking in the microscope from outside, I will not see a spot of light. The moment if I see a spot of light, I know that that eye is not being used. Ekdam clear chai. I have seen and I have corrected a 15-year senior surgeon કે ભાઈ તું એક જ આંખથી જોઈ છે. How do you know? I said, એક જ આંખથી જોઈ છે. Believe me. He would keep on arguing with me. I am 15 years in surgery and all that. सुन ना यार, तो सुन तो ले, शांति तो रख तू. तेरा I am not insulting you. I have nothing against you. जो दिखता है वो बोल रहा हूँ. He didn't accept. He continues that way, and I have nothing. I cannot go on beyond that. But that is what it is. So these are fundamental, absolute basics. Doesn't change. All right. Now this much is enough for microscope. Now when you adjust the microscope, you adjust the eyepieces to your focus. Specs I told you, up and down I told you. IPD is necessary to be adjusted. With respect to burrs, I'm told to talk about it, so ekdam short માં બધી વાત કરું છું તમારી સાથે, and what I feel at the moment is more important. Now these burrs are of various types. They are essentially two materials of which the burrs are made. One is steel burrs. They are not stainless steel. They are steel burrs. That means they will rust. And the other one is carbide burrs. Now carbide is carbon and tungsten ka mixture. It comes as a powder. It's like concrete. You give it a shape and freeze it. It's frozen for good. You can do nothing to it. जो shape दिया वो shape रहेगा. Because it's the hardest material after diamond is tungsten. Now if it is very hard, it is not possible to make it very sharp. If it is very hard, it will break. It becomes brittle. The harder the thing is, the more brittle it becomes. And because it is tungsten and carbon, it does not rust. Now, abadhano practical meaning is it will not rust. It can be reusable because it's hardest, so it does not blunt easily. But once it is blunted, it has to be thrown away. Nothing can be done to it. It's nothing. I mean, you can't melt it. You can do nothing to that. On the other hand, the steel burrs will rust. They are very sharp. They are very sharp because they can be sharpened. It's not very hard. A very soft material is very difficult to sharpen. A very hard material is very difficult to be sharpened. The steel hardness is possible to sharpen, and so if you use a steel burr, the moment you take it and start using it, you feel, wow, this is cutting like cake. And after half the surgery done, you have to throw it off. You cannot use it any further. Know this, because and the steel burrs are cheaper, sharper and cheaper. So you get absolutely mesmerized. આટલું sharp burr મને આટલા સસ્તામાં મળે છે, ઉઠાવી લે, 15-20 તો ઉઠાવી જ લઈએ. But be careful. I mean, I know as a junior, I have been once upon a time buying these burrs, and I have gone through. Now the third ones are the diamond burrs. They are not diamonds. They are again carbides, powder on it. And cutting burrs are to be used as much as possible, even when you are near a vital structure. Unless you are near the facial nerve but not on fallopian canal, say for example, that means there is some mustard bone also at that time on it, still continue using cutting burr if you are confident enough. Don't listen to me blindly, but balance it with your level of confidence. The reason why you would want to use cutting burr all the while is because the moment you use cutting burr, you use less pressure. If you use less pressure, if there is less heat, there will be less thermal damage to the structure you are wanting to protect. If you use a diamond burr, one, and two, old worn out diamond burr, and then you will use too much of pressure, you will create a lot of heat, and you are going to create thermal damage to your very organ that you are wanting to protect. So be aware about these things. ઘણી વખત વાત કરતી વખતે diamond protective and not damaging, true, but it is damaging in its own way. If you are aware about it, it will not do the damage. If you use a carbide burr, I told you it's brittle, so your speed cannot be more than 50,000 rpm. But if you use a steel burr, your speed can be as much as 1 lakh per hour per minute. 1,000 is whenever you are doing a mustard surgery, most of you will be doing that. All of us will have to do that all our life. 50,000 is good enough. But when you want to drill labyrinth, which is the hardest bone, by the way, do you know why petrous is called petrous? Petra means rock. Oil coming out from petrol is from Petra is petrol. Petroleum. Oil coming from rock is petroleums. I saw that and I was petrified. That petrified would mean I became statue-like. I became a stone. So Petra means stone, and petrous bone is the hardest bone, and that's why it is called petrous bone. So if you want to drill petrous bone, you need a 1 lakh rpm cover. So if you are drilling 1 lakh, if your motor is 1 lakh rpm, you will never use carbide burr, because if it breaks, it's a point blank shooting. While working, it can break. It's brittle. Steel is not brittle, so it is allowed. Technically it is allowed. So all your 1 lakh rpm ka burr, now people will come to you, these salesmen, sahab ye 1 lakh rpm ki motor hai, and you get impressed by those numbers, not knowing what those numbers mean. 1 lakh rpm ka motor to le liya, now you can't use carbide burrs, and you are not rich enough to use steel burrs every now and then. And then other problem is all this 1 lakh rpm ki motor will have a notch, because otherwise at that speed it slips. Burr and motor will slip over each other. So you have to have a notch so that it will not slip. And each company have their own style of notch. So तुमको उन्हीं का burr खरीदना पड़ेगा lifelong. So, they are putting you into a room and they will close the door. So be aware that you are getting into a room and the door is going to be closed. Be aware. I mean, what you are buying is ultimately an intelligent choice you make, but you can make an intelligent choice only if you have adequate information. Thank you, Taru. We'll go there. Now there is one, you ought to know where your sigmoid sinus is outside the bone. While making a drilling, you will see ultimately. But outside the temporal bone, that is surface marking of sigmoid sinus, is important because then there is something called retrosigmoid surgeries. So if you know where a sigmoid is, then you can do retrosigmoid or presigmoid surgeries. Otherwise, you can't do. So I will make a small surface marking as a beginning thing, and then we'll start with drilling.
Sir, Lisa sir has asked if we can speak about the magnification power.
All right. All right. Now, you see this is the mustard tip. You all will identify it very well. This is canal. This is zygoma. What is it? ये चलता नहीं ना ना पना सो इट्स अ स्टिल पिक्चर Now, let us talk about at what magnification you should be working. It's another very common topic for the beginners, those who start using microscope for the first time. Now, there is a difference between seeing something and doing. If I want to eat chapati, I see chapati, I break it and I eat it. So it's direct. There is nothing in the way. But if I have to see something through microscope and then do it, then all that I am doing is on an image. What I am seeing is an image, and on the image I am doing it. So unless you train your eyes to see the image and work on image, you will not be happy with microscope. And everything is magnified over there. So all that you are used to see, तेरी चपाती इतनी सी और morsel था, अभी इतना बड़ा morsel दिखता है वो. So you have to train. The seniors will find no difference. वो ऐसा ही दिखता है. I mean, after some 2-3 years, you are all set. 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 But the beginners find it very difficult. And worst is a situation when you do something here and look there. That is endoscopic sinus surgery. You are seeing now not only image, but you are seeing a two-dimensional image. It's at least under microscope you are seeing three-dimensional. In endoscopy you see two dimensions. So unless you train yourself, you can't see. Also, have you ever bothered, look at it and sometimes you will realize, look at your friend's face, somebody who is very close to you, uska face endoscope mein dekhna kaisa dikhta hai. It almost looks terrible. But when you put it in the nose, it looks normal. It is not normal. Your eyes have been trained to look at the sinuses from that perspective, so you think that is the way it is. It is not that. In fact, not only your friend's face, you definitely look at your friend's face through that once at least to see what you are seeing in the nose. But any other thing also, put your hand like that and see. The fingers look so tiny and the palm looks so big. It's completely distorted. So the point is, you have to train yourself, your eyes and hand, very well worded as hand-eye coordination. You need that hand-eye coordination here also. ये क्या हो गया? नहीं आया? All right. So you need to have magnification. That is the job of microscope. And what is the best magnification? Now, what is the best speed to drive on a road which is just outside, whatever the name is, Karamsad Anand Road or whatever, I don't know what is the name. There is no, do you drive at 100 ka speed, 50 ka speed, 20 ka speed, what? Do you look at your speedometer? You don't. You look at the road and you drive accordingly. So what is the best magnification? Is what will give you orientation of surrounding things. And if you do not have references from surrounding points and you are too magnified, then you get completely lost. The reverse is the case when you too zoom out, when you can't see the very structure that you want to see. That also is a bad situation. So basically you have a single word, put it as comfortable. Now what comfort would mean is two things. One, you should be able to see the structure. When I am doing a stay-piece footplate surgery, that means I am making a fenestra. At that point of time, I am keen on seeing the footplate, I am keen on seeing the oval window and a little bit around it. I am not any further interested in seeing pyramid, nor am I interested in seeing anything else. But when I am reviewing the overhang, I am definitely interested in seeing where is the fascia, chorda, where is the tympanomental flap, how much bone I am supposed to remove. Now at that point of time, if I zoom in too much, I will lose references and then I will do damage. So always remember two opposing things. One is references to the surrounding structures so that you know where you are. Just try to imagine that every time I see only this much and then I have to walk, I will find it so difficult, keep all the while hunting, step aaya ke nahi, step aaya ke nahi, aa gaya. But if I have a broad view, then I know where the steps are. The same thing over there. Oh, okay. Yes? Yeah? શું કહે છે શું કહે છે એટલે ડબલ ગ્લવ કર્યું એમ All right? Yeah. Are you on screen? Yeah. All right. Now, अभी है center में tip, mustard tip is in center. This is in center. All right. Now, if this is mustard tip, this is the posterior border of mustard, isn't it? Now, if I continue drawing line like that in the same thing, that means along this, and wherever it goes, there is a posterior border of sigmoid. And there is another confirmation. Is pick है क्या pick pointer कुछ तो भी. In this case, this is emissary vein. So this emissary vein is another thing that is telling me that the sigmoid is here. Generally, the emissary vein by length is the shortest vein. So it comes out straight from the sigmoid sinus into the scalp. So that these are the two ways on the surface you know where is your sigmoid sinus. All right. Now, if I was told to choose a temporal bone just now, what I was looking for quickly was how big is the mustard process. If the mustard process is big enough, I know indirectly that this is a pneumatized mustard. And I wanted to choose a pneumatized mustard because it's easy to demonstrate few structures. Very unfortunately, it means that you end up drilling a lot. Look at my back, it's absolutely straight. In fact, I remember in one of the workshops that we were doing, we had a foreign faculty who was with us, and he saw me doing some ear surgery, I don't know, whatever I was doing. He later on comes and says, I'm absolutely impressed by your back rather than anything else. So, I mean, a senior surgeon would know what is going wrong, just a look. So, I'm just telling you that you keep your back straight, repeating the same thing in different ways. Focus में नहीं, is it in focus? चलो ये लगा. Now, when you start drilling, obviously this is Henle spine, this is नहीं दिखता है, क्या हो गया? Yeah, much better now. Better?
You just adjust your pupillary length. The fine focus will be done from the external knob. This knob, it is for the camera focus.
Which knob?
This ring, sir.
छोड़ो.
Yes, you sir adjust your focus.
Alright, ठीक.
Yes. After that, the fine focus could be done outside. If it's blur outside, we can focus it.
Now adjust it. You focus somewhere on this, whatever is in the center. Focus now.
Yes, sir. It's done.
हो गया?
अजी clean कर दे.
ना तू कर.
Clear हाथ तक कर उन दो करो. Opposite करो. करो. बस.
Yeah. All right, good. Yeah, good for me also now. Thank you. So that is Henle spine का position है नहीं इधर. This is Massiven's triangle wheel line drawn from here, line drawn from the posterior tangent over here, and Henle spine together make a Massiven triangle. The point is, Massiven triangle is a representation of antrum as a surface marking. So now, why antrum is given? The only air cell is given a separate word, antrum. बाकी किसी को भी नाम नहीं दिया है. Names are given like retroorbital, not retroorbital, retrofacial, retrosigmoid वगैरह. But antrum को नाम दिया गया है. You know the reason? Largest cell and always present. constantly present in a normal development. I mean, if there is a gross anomaly, then it's a different story. But otherwise, it's a cell. The entire air cell system may be absent, but the antrum will be there. So that's why that is named separately. So now, because I know there is antrum for sure, and if I don't want to do damage to anything else, and mind well, you will come across situation where you make the first cut like that, and the bleeding starts from the sigmoid sinus as a huge, unbelievable amount of blood, because it's a very large vessel, and you have, it's a fortunately very low pressure. So the moment you put gauze, it stops. But then you are, in those few seconds, you are so lost, more as a junior, it will take 15 seconds before you realize where you are. Nothing to be worried about, just put a gauze over there and do. Then after that, the bleeding has stopped, and then think about it, whatever is best for you to do accordingly. Why am I telling you is, sigmoid may be here, and you start drilling here, the very first stroke will give you bleeding. Sigmoid will not be in antrum. So if I have to be very sure, ये बर कटता नहीं है, नहीं ये नहीं कटेगा, ये कोनिकल बर, लाइट खोलना थोड़ा सा, इधर लाइट आ जाए, इधर ये रोज बर दो. So I start my drilling at massive and triangle, least likely to cause any damage, because there is supposed to be antrum. Because there is antrum, वहाँ मिडिल क्रेनियल फोसा भी नहीं आएगा, लोअर टेगमेन भी नहीं आएगा, और उतना आगे सिग्मॉइड भी नहीं आएगा. After having gone by 2 mm deep over there, then I spread. And if you want to do temporal bone dissection in its totality, then you do this. पानी. Now this is my sigmoid line, sorry, not sigmoid, sorry, zygomatic line. Up to zygomatic line I will go. Can I reduce the magnification? Suction नहीं कर बेटा तेरे. So what have I done is I have removed 1 millimeter of bone all across. Of how much surface area is anteriorly the canal, posterior canal wall, उसके नीचे anterior border of pick posterior border of, anteriorly the posterior canal wall, anterior mustard wall, mustard tip, posterior mustard wall, up to the imaginary line that I have drawn as a sigmoid line, and then zygomatic line drawn backwards. Now that much is the area that I start removing. How much? 1 millimeter deep. Why that? Because I do not know where is my tegmen, I do not know where is my sigmoid, I have no clue. So I started first from the Massive triangle, which is a constant air cell, least likely to have any structure. Having done that much, now I remove just 1 mm. As I keep removing it, this is the cortex that I have removed. And that is why this sort of mustardectomy is called as cortical mustardectomy. Alright, all others are differently worded, but this is the only one which is called as cortical mustardectomy. It is a cortex which is removed, entire cortex is removed. Alright. Now, having done that much, I go now again from the Massive triangle. And this is the hardest bone, the lateral bone. After that, these are air cell partitions that you are removing. So they come out very quickly and they come out in large pieces. Because they come out in large pieces, each partition will break itself. That partition will block the suction. So your maximum problem with your suction starts when you are doing cortical mustardectomy, not when you are removing the cortex, but after that. Also, when you are drilling petrous apex, the bone is very hard, there are no cell partitions, the suction will behave the best. Alright? It's not that the ward assistant or OT assistant has improved, it's the bone which is like that. I'm sorry, I have to go into this magnification. તમને જોવાય જ કે ઓરિએન્ટેશન આવે જ ને મને થોડું વધારે છે પણ it's all right. So I've gone into next level, again the same way. Now the way I am drilling is, one, I am using the equator of my burr. I am not using the pole of my burr, I am not drilling like that. I am using the equator of my burr to cut, one. And two, my burr is never constantly, it's never to be done like this. See, this is the worst thing to do. You never drill like that. Your burr keeps on moving. And the larger the stroke, the longer the stroke you make, the lesser the chances that you will do damage. Sounds crazy and funny, but that's the way it is. You do it, after some time you will realize that the largest burr and the longest stroke are the safest things. At a place where the largest burr fits is the right burr. See this bone that comes out? These are large bones and they are cell partitions. Is this better or the previous one? Previous one? This is better? Alright. Focus में नहीं है मेरे लिए. ठीक है, देख तुम तुम्हारा फोकस एडजस्ट करो. Also there is another thing, you see there are two strokes. This is the active stroke, I am making an active stroke. Alright, now I lift, I move here, this is a passive stroke. I again now see this happening quickly. This is active stroke, I lift, I come here, I again put it to work and come here again. So active stroke, passive stroke, active stroke, passive stroke. You don't do this, you don't do this because the burr will run and it will damage surrounding important structure. So it is always active stroke, passive stroke, that is the way it goes on, and the active stroke is in the direction of the rotation of the burr. So if you have counterclockwise burr, then you will do it the other way around, whichever way. So now this burr cuts when the burr rotates in that direction. So in this way I will be working like this. When I come here I will be working in this direction. You get me? Yeah. Now active stroke is on the opposite direction, this way. Alright. Active stroke in this direction, active stroke in this direction, active stroke in this direction. Now, what I have done is I have gone further 1 millimeter down. Now, you do not do this, I am sure you must have seen your teachers not doing dissection like this. That is the difference between a temporal bone dissection, where you want to learn the entirety of the temporal bone, and doing a cholecystoma surgery, or doing a tympanoplasty where you want to make an enteral hole, which are very different situations. I am now at the moment trying to tell you how to do a temporal bone dissection. So this is the way you will do cortical mastectomy. This is the way you would do for Radical mastectomy, this is the way you would do for petrosectomy, this is the way you would do for any other surgeries in which removal of hair cells is a part of it. But when you want to do an enteral hole, this is not the way you do. Be very clear of that. Another fundamental principle, absolutely fundamental, that doesn't change, will not change, is the fact that you work always in a pond. You never work in a hole. You never work in a well. Don't create a deep thing inside where you just can't reach. There are three axes. If I can, hey, do you have a pen paper? हो जाएगा. हाँ ये दे, दिस इज ये उठा ले, ये रहने दे, नहीं तो रख दे, इसको रख दे, रख दे, रख दे, रख दे, रख दे. You see, ये एक fundamental principles है. You should know this. If this is the vision in which, this is the visual axis, we call it as VA. This is illumination axis. We call it as IA. And your instruments neither can come from visual axis because it will obstruct your vision. It cannot come from illumination axis because it will obstruct the light. So it has to have a third axis, and that is the axis in which you are working. So this is the third axis in which you are working. So your opening over here has to be this large for you to work in this area. That is precisely what happens when you do stepidotomy with a very small opening, with a very limited pony overhang removal. When you start, you see everything. Good illumination axis के लिए अच्छा है, visual axis के लिए अच्छा है. The moment you put instrument हो जाता ही नहीं उधर. जहाँ जाना चाहिए वहाँ नहीं जाएगा. And then you घुसड़ किया, and then all the complications. It is at that point of time that happens. So don't do this. Have these things very clear. Now, you see my pen? Yes. You see the shadow of it? That means the visual axis and illumination axis are not in the same line. Do you know a situation where the visual axis and illumination axis is in the same line? रोज देखते हैं हम लोग, रोज यानी हफ्ते में 2-3 बार तो देख ही लेते हैं. Pictures taken with a flash. If I take anybody's picture with a flashlight, that face looks very different. You can recognize that this is so and so, but you know that it's not the same. What is the difference is because you are used to seeing everybody's face with the shadow of the face itself. तुम्हारी नाक का shadow तुम्हारे lips पे आ रहा है. The mind is so trained to see faces with shadow that we take shadow as a part of the image that we have. And the moment those shadows are taken away, that is what happens in the flashlight. You find the face very different. Now, it is important that we have this because, you see, normally we have 3-dimensional image because we have 2 eyes. Like I told you the example of my friend who did all his surgery for last 15 years with 1 eye. How was he doing it? He was doing it because of the shadows. You all should know that there is a full-blown science called physiology. It's a fully developed science. Let me talk. I'm sorry. I hope you don't mind me stopping this and talking some nonsense, because that is not.
Covered by other autologists.
No, I mean, આ બધું બોલાતું નથી. So, and I feel that is important. So, SIA. SIA. SAI, sorry, physiology. Anyway, physiology is a fully developed science in which shadows, it's essentially dealing with shadows. Now, if I see with 1 eye, I still can make out who is in front row and who is in back row. I still can make out so person is so and so. without me having three-dimensional vision, because I'm seeing with one eye. That is because the mind is so trained to see shadows that it's by shadows that we make out which is in front and which is behind. Now, exactly reverse happens when an ophthalmologist wants to see the posterior capsule of lens. He does not want shadow. So the visual axis and illumination axis in an ophthalmic microscope is less than 5 degree, less than 3 degree. So 0 to 3 anything. For ENT microscope it will be 5 to 7 or 5 to 8, something like that. That angle is vital for ENT because that is the only way you can get those shadows. And वो shadow आता है, तुम लोग को मालूम नहीं है कि वो shadow आता है, but you know कि वो shadow है, इसलिए क्या चीज़ आगे है, क्या पीछे है. And if you use ophthalmic microscope to do ENT surgery, after a while you will realize कि कुछ अलग है. क्या अलग है पता नहीं चलता है, ये अलग है. Very unfortunately, all the salesmen who come to sell you microscopes, they have zero knowledge. उसको खाली कितना रुपया है वो मालूम है, बाकी कुछ मालूम नहीं है उसको. वो बोलेगा बहुत कुछ, it's all non-scientific. This is genuine, true science. So you ought to have work in a pond and not in a well. Create as large a pond as possible because then under whatever happens you have enough access of approach to from various angles to that particular problem. वहाँ bleeding शुरू हो गया. So you can put 2 instruments. Your assistant can also come in. Otherwise you just cannot do anything like that. You have very limited. Only one hand can go in. The second instrument जा ही नहीं सकता उधर. Now you are working on a footplate of stapes. You put in your prosthesis and it is bleeding and you want to suck. How do you suck? You just can't go in. ऐसा बहुत सी बार. The problem of stapes surgery is the simplest of surgery if exposure is good. If exposure is not good, it's the most complex surgery. This happens for almost anything, but becomes very vivid for stapes surgery. Dhaval, this is all right the way we are going, or you want me to only do dissection and finish it off? And I am genuinely asking you because I can keep on talking nonsense a lot. I am known for talking non-subject. Girish, करूँ ना everything? इसी पे फोकस होता है, उसमें फोकस नहीं होता है. चलो, all right. Now by now, depending from bone to bone, some of the bones may show bones may show sigmoid sinus by now, some may not show. So if you start seeing a plate of bone, then you know that you are on the temporal sigmoid sinus. What is it? You can see plates getting defined. Now all that cortical mastectomy needs to be done. I am talking of cortical mastectomy, very rarely performed in life. In real life, the only indication for doing only cortical mastectomy, that means that is the end of surgery, is coalescent mastocytosis. Rare disease, very frequently missed out as a diagnosis because the patient doesn't get pain. He gets either dull pain or no pain, or just a swelling over there, or just a little discharge sometimes, and it's all settled and all that, and it's frequently missed out. So if you see a coalescent mastocytosis, that's the only true indication for doing only cortical mastocytomy, which is what we are doing just now. And in this cortical mastocytomy, you have to define. Focus नहीं आता यार. So this is a suction. Now this fine tuning you do a little later, which is what I am doing. Little later means superiorly the border can be very high up, way beyond zygomatic line, depending on amount of pneumatization. To begin with, you don't go there. It is only after having drilled a little bit that you can now go there. And I am going way, this is my zygomatic line, and I have gone way superiorly. I still can't see any plate of bone. You can make out this is a partition and this is a cell. You can make out, it's possible to make out, and that's why it's possible to define a plate of bone. That's antrum getting opened up now, or maybe still it's a periantral. No, it's a periantral hair cell, because if, how do I know this is antrum or not? Yeah. So if I see the lateral semicircular canal, then I know that it is antrum opened up. All the while it's a wide opening.
wobbles like this, anything to do differently? At some places the bar is
The
wobbles.
burr jumps. You can call it wobbling, but it's actually the burr jumps. That is, I mean, you have to hold your handpiece rather firmly against what you are doing. If you are holding it loosely, then it jumps. And when you are using larger the size, the more the jump it makes. અને અહીંયા વોબલ કે જમ્પ કરે તો વાંધો નહીં. The reason is because there are no important or vital structures around, you know. Let me now do aticotomy also. I do not know whether you people are in focus. If you are, then I'm happy. Focus. Not centralized. Better? छोटा बर देना मेरे को. Rose burr, same type of burr.
Sir, outside tea and some snacks are there. We can proceed same after you finish the cortical, sir. If you have.
Yeah, all right.
Yes.
मैंने बताया. हाँ लगाड़ चल लगाड़. I think you put this burr. So that is lateral semicircular canal here. ऐसा रखो. Now what I am drilling just now, you may not be able to drill in all cases. This plate of bone and this plate of bone can be too close. In fact, there can be a temporal bone in which it is only one plate of bone. There are not two separate. This will happen only at the lateral portion. At the medial portion, it always separates out because it has to create a place for tick for malleus head to be accommodated. So you have a situation where the the dural plate and the canal plate is 1. So how do you do etechotomy in that cases?
smaller one.
Yeah, કેટલો પણ small વાપરે, if that's a one single plate, so you will damage that plate itself right by your drilling. So these are the only cases in which it is obligatory for you to do inside out technique. This is obligatory. I mean, there is no other way you can do it. The rest is your choice. इधर उधर चले. I mean, मैं हमेशा यही करता हूँ, मैं हमेशा वही करता हूँ. This is obligatory. All right?
This area, to use the equator, we are bending the wrist little bit and making the
Correct. Wow, super.
not ergonomically,
Correct.
but it helps.
Yes.
We
You
use the equator as far as possible.
yes, use
તાલીમાં રહેશે કે આમ જ શાંતિથી કર્યા કરો, હાથ આમ પણ કરવો પડે.
sometimes you have to do it. That's exactly what it is. You are right. I mean, you cannot see, but I'm doing my hand like this,
Wrist bend કરવી પડે.
so that the equator is what is drilling the anterior canal wall or anterior atic wall. Now, how anterior you go till the anterior canal wall. You can see anterior canal wall here, and anterior atic wall that you have made is one in the same line. This is for most of the other surgeries. If you are doing a cortical mastoidectomy, then as far as the cellularity takes you, this can be as far. This can be even nearly half of the zygomatic arch. It can be pneumatized that way, and generally coalescent mastoiditis are highly pneumatized mastoids. So you have to be prepared. Your skin incision begins that way.
People call it extended cortical mastoidectomy.
Yeah,
Indication would be coalescent mastoidectomy.
it is coalescent mastoiditis. If you are doing a
These are cellular mastoids.
this pneumatization can go into the zygoma, zygomatic arch and zygoma also, because it is in the arch somewhere halfway down that zygoma ends and the temporal bone begins. Or it can go into up to the temporal bone, and behind the temporal bone is occipital bone. The pneumatization can be in the occipital bone also, and you have to remove them. And another thing, as far as etechotomy is done, is I have not removed this medial wall. You see this? I have left it behind. And now the disease is more in the atic or antrum. Normally, a small cholesteatoma, where it will be? Atic. But you always end up doing enterotomy. ऐसा क्यों करते हैं?
Classical way we are taught.
हाँ, but ऐसा क्यों करते हैं? There is a reason for it.
Non-disease area to disease area.
नहीं, पर नॉन डिजीज में न जोवाए तो then why would you still do etechotomy? The reason why you do it is because enterotomy is the simplest possible procedure on the temporal bone, whereas etechotomy is the most difficult of all procedures
Dangerous, yes.
and dangerous. And unless you do it in a specific way, that specific way is that medial 1 mm or 2 mm is left behind. And I'll show you what to do with that now, so that you don't damage the ossicles. That medial 1 or 2 mm are left behind, the rest is removed. The rest is all easy to, and it's possible. Specifically when you are coming from inside out like that. If you saw me, I was drilling from inside out. So it's possible, medial to lateral. But when you come to the medial 1 mm or 2 mm, it's a different strokes, which we'll do it now. Now in the whole process, what I have done is I have defined the plates of bones. That is, this is canal wall, superior canal wall, anterior mastoid wall, mastoid tip, posterior mastoid wall, posterior margin of mastoid dissection, sigmoid plate and tegmen plate, and sinodural angle here. All right. Now I need a little more dissection, little more air cell removal medially to define things further. We will come to this removal a little later. I will not go medial to lateral semicircular canal or posterior semicircular canal. I will stop at that point of time, and because the dissection style changes, I am now defining my sinodural angle properly. It's a complete definition of sinodural angle. There are no air cells seen any further now. Are you in center? Now these air cells are very different. You can see that now these air cells have marrow. Generally this is an adult bone. Generally there will be no marrow, but there is marrow here. What is this? First year resident, what is this? Only first year residents are allowed to answer. What is this? Alright, second year residents, digastric ridge. Yeah. Gastra means पेट, isn't it? Gastric ulcer, yeah. उसको दो पेट होता है, diagastric. Alright. And posterior belly, now I do not know whether you know this, all the muscles that develop from branchial arches are never inserted on bones on both sides. It's very peculiar about branchial arch muscles. All the muscles that develop from that, either they are inserted in another muscle, that is digastric, classical or omohyoid, or they are inserted on a cartilage. They are inserted on bones on both sides, that's not possible. ऐसा भगवान ने क्यों किया है मुझे नहीं मालूम है, लेकिन ऐसा है. They are inserted on skin. Which muscles are inserted on platysma and facial muscles, all facial muscles. And there is one more muscle inserted on skin in human beings. No, ये બધું facial માં આવી જાય ને એટલે they are all facial muscles. So all facial muscles, that is two special facial muscles is front occipitalis and platysma. There is one more muscle not inserted, nothing to do with branchial arches, dartos, scrotal muscle. They are skin, they are inserted on skin. And these muscles are called as carnosus muscles. And you cannot, यहाँ अगर मक्खी बैठ गए तो मैं मेरी स्किन ऐसा करके नहीं कर सकता हूँ, लेकिन गाय भैंस कर सकती है, जहाँ मक्खी बैठी हो वो उतना हिलाती है, उतना ही हिलाती है. You and I can't do it because they have carnosus muscles all over the body. फालतूनी बધી વાતો ઘણી કરી છે હું, I'm sorry, but
Interesting, at times they are very relevant.
yeah. Alright, now there are some few air cells. Now these are the last air cells to be removed, and you will see my strokes of my burr changing, in the sense that all this time I was using full force and full speed. My speed may not reduce, but my stroke will become like paint brushing, gentle strokes. That is because I don't want to remove large pieces of bones. Now I want to remove small pieces of bones on large area. So I will be very long strokes, but the strokes will be gentle because I am expecting some structure over there. Which nerve? Sciatic nerve, first year resident. See now the strokes. I can see some structure coming up. You can see some line here. There are some air cells still over here left behind. Yeah, I'll remove that also. You see how I know that there are air cells is the bone is very different. This is a plate. There is a jali over here. The jali is air cells. Don't worry, I will not make a hole.
Can you call that peri-labyrinthine test?
શું કહે છે?
Currently, whatever cells you are eradicating, can you call that peri-labyrinthine?
These are on the canal wall. What I was just now removing was on the canal wall. આ લેબરિન છે, તો અહીંયા આવશે તો લેબરિન્થાઇન થશે, પણ આ તો કેનાલ વોલ છે, posterior canal wall. Now these last air wall becomes very vital if you are doing posterior tympanotomy or you are doing cochlear, cochlear implant, because if you have a thick posterior canal wall left, then you can't see round window. The reason why I am not likely to make a hole are two. One is large strokes, long strokes, and two, I am removing only air cells with a large burr. If I was to use a small burr, I would be very afraid. You can see some white line here. Can you see a white line? Yeah. You see a pick pointer. ऐसा नहीं, ऐसा देने का मेरे हाथ में. You see a white line here. Now this white line is some structure, we will know what it is, but you see some soft tissue here which is also in the same direction and whitish. Now is this facial now? Is this facial now here? Is this facial now here? Or is this facial now? All are facial now, multiple branches. Sir, not bifid but multifid facial palsy or facial now. ये तो facial है, all right.
The scallival calci.
हाँ.
He goes the state and these are tissues outside the canal.
And what are they? That's one of my favorite things to talk about, and they are called as Sharpie's fiber. Important છે સાંભળો. What happens is any periosteum when it is attached, the pull of the muscle exactly opposite to that. The fibers of the periosteum go deep inside for the periosteum to take a full anchorage onto the bone. These are Sharpie's fibers. These are periosteum of the sternocleidomastoid which have gone inside like that. Now they run in the direction of the facial nerve, not because anything to do with facial, but everything to do with the sternomastoid muscle. Pull. In male temporal bone, you will see them far more well developed. Now, why that is important is if you happen to dissect like that, now most of the time you will end up doing cholecystoma, छोटा सा cholecystoma होता है उतना हो गया बंद करो. So you don't see this. But if you have to do anything more than that, now yesterday we could have seen it, but yesterday was a blood day, so you couldn't see. But if you dissect like that, you will always see these fibers. And if you are not aware about it, you will be terribly afraid that you already damaged the facial nerve, उसका खाली टुकड़ा रह गया है. For facial nerve to be damaged, if you cut the facial nerve, you should see two ends. दूसरा end नहीं दिखता है तो don't worry, you have still not damaged the facial nerve. It's simple. दो एंड तो दिखने चाहिए ना. ढूंढो, I mean, तुम ढूंढोगे नहीं और कट लिया है तो अलग बात है. नहीं हाँ, partially tear होता है तो you will see the nerve. And another way of, very certain way of doing, you are drilling and you think it's an abnormal course of a nerve. Now you think you're not sure, ये nerve है या mucosa है. Thickened mucosa is very likely to look like facial nerve. Now you don't know how to proceed from that point, because वो nerve है तो अलग बात है, nerve नहीं है तो अलग बात है. I mean, it's a different, your actions are different. It's very simple. जो from that particular point wherever you are, वो nerve का एक direction होता है कि ये direction में जाएगी, ऐसा तो नहीं जाएगी वो nerve. So on the projected direction of the nerve, you start drilling. If you see the same thing continuing, you know it's a nerve. If you don't see anything coming over there, then you know it is an air cell with a bulging mucosa into that. It's very simple, it always works, always. I have never failed on that. I am now told of a very nice thing for all of you. Tea is available. So let's break. नहीं, इसका ऊपर ही इसका might be a question with that might be a question with all, that might be a question with all of you. Hey, pakad. All right. You see, if the burr is rotating in this direction, that means, let me stand like that, clockwise direction. Then over here, it is in forward direction. If this is the surface, barabar hai? But if this is the surface, it's not in forward direction. This is not forward. If it is rotating in this direction, then this is forward. If it is rotating in this direction, then this is not forward. This is forward. Do you understand that? You want me to repeat? Absolutely no hesitancy. सब अपने ही है, सबको मालूम है, हम सब गधे हैं. So, I mean, no hesitancy. काहे को, किससे डरने का है? I'll repeat. If this is the direction in which it is rotating, then if I move in this direction, it is forward, isn't it? Now, if this is the direction and I rotate in this direction on the posterior part, then it is in the wrong direction. So, I have to come in this direction now. अगर पीछे आगे से है तो ऐसा, पीछे से है तो ऐसा. Now, if I draw a circle, you will get it more clearly. Imagine a circle here like that. ये वो पेपर है क्या? बोन पर नहीं था ये. उधर उधर करना पड़ेगा. माइक्रोस्कोप. Under the microscope, I am the only one who can make drawings, because I find it most useful, Now, if this is the circle and this is the burr which is rotating in this direction, all right, clockwise. So, I have to drill in this direction, isn't it? Over here I will have to, this is the direction, over here I will have to drill in this direction. Over here I will have to drill in this direction. These two are opposite. You get me now? That is what I am trying to tell you.
Which magnification line to use?
Pachu bolo, please.
Different magnifications, what does exactly they mean? Like 1, 1.6?
No, this.
Object should be seen and references should be
But that is,
But probably
what is one magnification? One magnification is not magnified once. It is not so. These are arbitrary numbers. This has no meaning to the number of times the image is seen larger. It has absolutely no meaning. One magnification generally means that there are, you see, what we use, આપણે બધા આપણા 10th ના બચ્ચાઓને 9th ના બચ્ચાઓને, I mean, we teach our children that there is a lens which magnifies. If you put 2, it becomes a compound lens, and this is magnified. That image is picked up by this and further magnified. These are all compound microscopes. So, if you do not magnify by the magnification which is given by the objective lens, then it is 1. If you make it smaller, they give some other number, 0.4, આમાં પર 0.55 આપેલું છે. But 1 means that whatever magnification that is available by objective is the one you are getting. Anything more than that is the number of times that objective has magnified એનું જે પેલો cylinder હોય છે ને, whatever that cylinder is doing, that cylinder is the one which you rotate.
multiple lenses.
However, now it is like this. There is one lens here, other lens here, then second position, then third position. So, one position there will be no lens. Now the practical thing is, you will always find that if your cylinder is lensમાં problem હશે, so when you put it on one magnification, it will be very clear. Any other magnification, it will be bad. So you know that cylinder is the lens in cylinder is the one creating trouble. And one magnification will always be 12 because this is one and this is also one. Whereas all other would be અહીંયા 1 હશે, 1.5 હશે તો અહીંયા 0.44 હશે. That way. There are 6 positions always, 3 lenses or 3 cylinders. You get me? Madam, તમારો જવાબ મળ્યો? The most difficult surgery of the basics, I'm not talking of Petrus surgery, is cortical mastectomy. If you have performed a good cortical mastectomy, from that point onwards, everything is literally either thoda drilling kiya, udhar thoda drilling kiya, and it now you will see suddenly, so many things that you thought once upon a time difficult to do or only boss can do, you start feeling कि ये भी कर सकते हैं. The reason is, most of the time you cannot do it is because you have not performed your cortical properly. So we have performed cortical. Now let us see, we may do first posterior tympanotomy as the first exercise, and let's see how difficult or it is. It will be not more than 5 minutes job now. Every exercise from this point onwards, inclusive of supposed to be most bombastic one, endolymphatic sac decompression. My God, only very senior people can do it. ऐसा कुछ भी नहीं है. All you need is temporal bone patience. There are 4 bones within this bone. One is, of course, very well defined anatomically. The squamous bone, the petrous bone, the styloid bone, and the tympanic bone. Now, why are they defined like that? Why are they defined like that? वो एक ही तो bone है. फिर भी उसको अलग ऐसे 4 पार्ट क्यों किए हुए हैं? The reason is, styloid process develops from a completely different source, and that is second branchial arch or second branchial arch. Perfect. So styloid develops from second branchial arch. The squamous part of temporal bone is what is it? Desmocutaneous bone. That means it develops from the embryonic ectoderm. completely different source. The petrous apex develops from yet completely different source, and the tympanic bone is not the bone of temporal, part of temporal bone. In crocodile or all those spouted animals, it's a part of lower jaw. Now it's ये into inverted commas फालतू की बातें हो गई, हमको क्या लेना देना है उससे, but I'll convert it into our language, our importance. That is the reason कि बोल रहा हूँ. Absolutely nothing to do with temporal bone, but might make your vision broader. If you look at these names, Bartolomeo Eustacio, ये कहाँ का आदमी हो सकता है? Bartolomeo Eustacio, have you heard this man? Will he be from Italy? Will he be from England? Will he be from Africa? Will he be from India? India में होगा तो शर्मा होगा, मेहता होगा. Bartolomeo Eustacio, the word, the spelling, the sound itself tells you that it's Italian. So, all the words, a lot of them are all named like that. Also, let us say mastoid. Masta is breast. Looks like breast is mastoid. Now, funny name, लेकिन आया कहाँ से? These are all Roman words. It's the Roman people originally, that time Italian, who started doing human body dissection. So उनको जो दिखते गया, ये किसके जैसा दिखता है, ब्रेस्ट के जैसा दिखता है, ये कैसा दिखता है, एप्पल के जैसा दिखता है, ये कैसा दिखता है, हैमर के जैसा दिखता है. Malleus is hammer, so malleus. Now this is the only place where malleus and malleolus would mean small. A large thing is malleolus and the small thing is malleus. Funny, but that is the way it is. What I am trying to tell you is they are all Roman or Greek words. And all the names, human names attached, are all Italian names, because that is the place who started doing the dissection. Years later, the whole thing shifted to physiology, which was mainly centered on France and Germany. Italian se hat gaya tha abhi. So all the names, William Harvey or Levoq, or all these are French names or German names. So anatomy and physiology got developed. Then came clinical science. The shift, center of excellence shifted to England. So you have Mayo Clinic, you have Graves' disease, all these are English names. You will find all clinical are English names, all anatomical names are Italian names, or Greek or Roman origin words. All physiology is human names attached are French or German names. From there, the whole center of excellence shifted to America, which is a complete mixture of, everybody. There could be Johnson over there, there could be Sharma over there, there could be anybody. Because that's a country which is importing people who are doing good. Tum aa jao. So, if you, be aware about this. That's how the science center shifted, the medical science center shifted. By the way, sorry, तुम्हारा बहुत टाइम खराब कर रहा हूँ, लेकिन मुझे इम्पोर्टेंट लगता है इसलिए बोल रहा हूँ. The first printed book was the Carpo Humano Fabrica. The fabrics of human body, translated, is the first printed book. Printed books में जो first book आया, that was this. It was printed, it was authored by Ingres. And Ingres is the one who first discovered malleus, incus bone. The first printed book was anatomy book. That is the time when they started doing anatomy dissection. So revolution, the medievals, क्या बोलते हैं उसको, Renaissance, if you know what Renaissance is. Renaissance came around, bringing in printing technology, bringing in human dissections, bringing in art and science and everything together, and this developed. Know this, I mean, because ये तुम्हारी book है, it's a medical book. All right, pick देना मेरे को. तुमको वहाँ कितना अच्छा दिखता है मुझे नहीं मालूम है. But if you see, this is a mastoid bone and this is a fallopian canal. They are distinctly different color. You cannot miss out. You cannot miss out. If you are looking for it, you will see it. If you are not looking for it out, of course, they all look same. No, color means, I'm sorry, shade is a correct word. It's a different shade. But yellow white છે, but this is a little whitish. The other whitish, yes. Correct. It may not be whitish, it is different, because if it's very vascular, it may be pinkish also, but it would be different. It will not be the same color, same shade. So, a chota burden. Now let me do a posterior tympanotomy, and if I know where my facial is, what is the problem now? Just lateral to facial, I have to drill anterior, and there will be no light लगाना. चला नहीं खस में नहीं है जो अलग है. ये छोटा लगेगा, इससे भी छोटा लगेगा. Now this is my facial now exposed posteriorly, isn't it? Right. Now I have to go lateral to it and drill anterior. So that is the direction. Again, long strokes. A focusing करो. Long strokes along the direction of the nerve, not crossing the nerve. In live also I would be using cutting burr. It's not that because it's cadaver I am using it, and I am using very gentle strokes. That seems to be chorda. Can you see that? ये छोटा वाला देना। इसके यहाँ थोड़ा लाइट लगाना, क्या तुम्हारा मोबाइल का लाइट लगाना है इधर। हाँ, या सो नाइस। वही सा इसका नो, ये बहुत ही छोटा है। हाँ चलिए लगा, इट्स ऑलराइट। Now you do come across sometimes cells over here. They are frequently called as sentinel cells. Sentinel would actually mean sipai, guard. Yeah. Sentinel node, sentinel pile, sentinel cells. Now, having gone up to the anterior one, now I should turn medially. Now I am drilling medially. I am going. Can you see that I am going deeper now? ये posterior है. I drilled anterior till I came to the anterior margin of the facial nerve. The moment I came across the anterior margin of facial nerve, I started going deeper. That is medially. Now this is important and I will explain you why. You can see water sucking from here. I have entered the middle ear now. Alright. Now, why this is important is a pen paper then. What is it? Sulche beta. So kai mane. You see, if I draw this as, are you in focus? If this is your posterior canal wall, this is annulus, sulcus rather, this is sinus tympani, facial recess, this is your facial nerve, this is sinus tympani, promontory का ये facial nerve, ये stapes, and then promontory and whatever. You understand? Now this facial nerve, if it is like this and you are coming from here, then you are in the good direction and you will be all right. इसका कोई भरोसा नहीं है, ये कहीं भी हो सकती है. This facial nerve in relation to this annulus can be here, it can be here, it can be here, it can be anywhere. The mastoid, the vertical segment of facial nerve is in approximately that area. Final position is not defined. Now, if I have a situation which I will never know of this kind, then I have hit the facial nerve from here. I go on top of it, and if I continue straight, I will come in the external auditory canal, not in the middle ear. To avoid that situation, you do not know where your facial nerve is in relation to annulus. You cannot see both the structures together. So the best way is to hit the facial nerve from behind, go on top, lateral. The top would mean lateral. Go laterally to it, and then once you've gone up to the anterior margin of the facial nerve, start going medially. And when you do this medial dissection, it is essential that you will leave behind this bone pick. You will leave behind this bone over here. Why? Is because the आगे से facial nerve turns anteriorly, and if you continue to go medially over there, you will hit the tympanic segment of the facial nerve, and you don't want that to happen. Yeah. हाँ. हाँ, that's another way of doing it. Yes, I mean Mishra sir કહે છે બરાબર છે. The other way of doing it is you define the posterior, or rather the short process of incus. Let me show you that. ये थोड़ा बड़ा देना है. अभी जो यूज कर रहा था ना. आया? Yeah, all right, good. Now you can see the short process of incus. Now you remain in line of short process of incus, and focus में है क्या तुम लोग? I am not in focus, but anyway, इसकी line में you come down here, and you that will be the right place for you to do posterior tympanotomy. But I mean that is one way of doing it. A defined way, more safe. Not identifying the facial. I personally feel, I think it would be more of a choice of things. I personally feel that what I want to protect is facial nerve. So if I have defined facial nerve, I am not likely to damage it. That's the way I look upon it. But these are important other way of looking at it. You identify the, see now short process of incus can never be in external canal. While doing cochlear implant, you definitely don't want to make a hole in the posterior canal wall. That is absolute no, because if you, one, your sterility is compromised, and two, you will have to close it anyway, because you can't leave it open with a cochlear implant in position and cholesteatoma developing over a period of time. So you must close it. So best thing is not to create it. The way not to create it is not to go lateral to the incus short process. Incus short process is a definite middle ear structure, nowhere else. So you take that as a landmark, go in line with that and do it. But at the same time, you want to protect the facial nerve. So you hit the facial nerve from behind, identify the facial nerve, go on top of the top would mean lateral to it, and having gone laterally anterior enough, you start going medially. You will, I do it that way, and that's, I feel, is quite safe. Whatever may be the position of facial nerve, it does not matter what the position of facial nerve in relation particularly to annulus. તમે કઈ રીતે કરો? इनकस आइडेंटिफाई करें, यू टेक दैट line.
in the cells within the facial. We eliminate the facial as well.
हाँ,
Since the position of the facial is quite variable, as you
करेक्ट.
rightly mentioned. Mucus is very stable landmark.
हाँ.
So identify the triangle and identify the sentinel cell as well. So then
So you heard what professor said, yeah? All right. Now, if I have to do a posterior tympanotomy, classically defined as opening up the space from the mastoid cavity between facial nerve medially, what now? Chorda laterally and incus short process superiorly, or bridge of bone superiorly, whichever what you are keeping. Between that, whatever you open is posterior tympanotomy. ये फोकस करो तुम. इसको मेरे पास में लेना यार. कैन यू प्लीज टेक इट? आई एम सॉरी. इधर ले. या थैंक यू वेरी मच. नाउ if I continue drilling it downwards, ये छोटा वाला दो. Now if I continue drilling it downwards, now there is a very thick bone. This is rather unusual. I am now going to cut the posterior, the chorda. And if I cut chorda and go down, then it is, उसको कुछ नाम है. Yeah, what is the name? Extended, yeah. थोड़ा कम डालो पानी. So now I am doing extended posterior tympanotomy. All the strokes are very different now. Very thick bone. थोड़ा बड़ा हो गया. वही जो अभी यूज़ कर रहा था. हाँ. Incus. Depth nahi hai. From this perspective, all you are seeing is the short process of incus. incus ની જ વાત કરે છે ને તો. So incus will tell you at what depth, at what line you are supposed to make posterior tympanotomy. It's exactly in the same line. I'll show you. Pick. Yeah, thank you. You see, this is incus, short process, this is the tip of incus. Yes? Now it's in the same line. So you can't go, if you go lateral to this, you will go in the external canal. Don't want to go there. So the danger is laterally you go in the external canal, you don't want to go there. Medially you go, you will damage facial nerve. So Mishra sir कहता था एवरी रीते the best way is to identify facial nerve, you will protect it, identify short process of incus, which is a definitive landmark. Facial is not a definitive landmark. And then go. And I mean, I personally go lateral to it and then start going medial to it once I have crossed the facial nerve. And I explained you why do you have to go medial. ये बड़ा वाला देना, बड़ा वाला दो बेटा, सॉरी. डालो पानी डालो. Yeah. All right. Now ये पूरा कर देता हूँ मैं. Right now, who first defined posterior tympanotomy? Who is the name associated with posterior tympanotomy is William House. Why did he do? William House brought in 2-3 things or 4 things which is remarkable, which changed the ENT completely. And you know who he was? He was not an ENT surgeon originally. He was a dentist. He passed as dentist. He started his dental practice and he got fed up of it. He said, I don't want to do dental practice. Only can happen in America, nowhere else. He then thought of joining ENT. He passed his ENT exams. But because he was used to drilling, he brought in suction irrigation and drilling in ENT. A major change, because prior to him, it used to be chisel and hammer. Gouge and hammer, not chisel. The difference between gouge is they are curved, chisel is straight. The other thing he brought about was diagnosis of acoustic neuroma in its early stages and middle fossa approach. It was he who brought in middle foci approach. And the third crazy thing he did was he entered inner ear. He was the first fellow to put in an implant. And दुनिया भर की गाली सुन के मर गया वो. Everybody, particularly the colleagues within America, criticized him to no end. And his misfortunes were abundant enough. With a lot of coaxing, he made his engineer friend to agree with him कि हम करते हैं ऐसा. It was a single electrode implant. He implanted in the inner ear. And the patient could say, I can know that there is sound or there is no sound. Beyond that, there was nothing else that could happen to him. And his colleagues criticized him that inner ear is not an organ to enter. You bring in a lot of infection, the patient would die. The patient didn't die. And खाली आवाज है या नहीं है उससे कुछ फायदा नहीं होता है. So don't do it. To the utter misfortune of Billhouse, वो इलेक्ट्रोड कुछ दिनों के बाद टूट गया, तो उसका वो जो सुनना था वो भी बंद हो गया. तो फर्दर क्रिटिसिज्म, बोला था पहले से नहीं करने को, गधा है तू करता है. Further to his misfortune, he and his engineer friend had fight and they dissociated. The implant program ended there. But remember, તમારે બધા જુનિયર્સને કહું છું, specifically addressing to you young guys, if you have an idea and if you believe in that idea, work for that idea. Let your colleagues say whatever they have to say. You will be criticized. The more radical the idea, the more criticism you will get. Don't bother about that criticism. वो बोलते रहेंगे, but you believe in your idea, you work for it, and you will succeed. Success is the only thing that will come to you. Take all my words the way they are spoken. Have an idea, believe in that idea, work for that idea. The idea is yours. Most of the time you stop, you have an idea. All of you, I know, you have 100 ideas by now. None of you work for it. And half of you even don't believe in your own ideas. It's not that idea that I'm talking about. I'm talking of an idea in which you have a belief कि ये ऐसा ही होगा, ऐसा ही हो सकता है, दूसरा कुछ नहीं हो सकता है. Then you have to work for it. और वो work के लिए फिर कुछ भी हो सकता है वो. I mean, depends on what the idea is. And it's you who have done it. So this is what, it was his idea to put in an implant. Voltas, by chance, the word from which volt or voltmeter comes. Voltas was the first person who experimented and said कि कान में करंट लगाते तो आवाज आता है. That was the first beginning of cochlear implant. Sorry, फालतू नहीं बात करूँ so तुम्हारे लोगों के साथ है, but I feel that this is interesting. This is what will make you, arise your interest in ENT. That's what interests me in ENT. So Voltas was the first fellow who did that. After Voltas, that is 3 centuries ago, it was the second person was William House. He actually implanted. He actually got the result also, but you can understand the crudeness of it. Engineer friend not willing to work for him, criticism of the entire American Otolaryngology Society, and lastly the breaking of the electrode, stopping of that whatever sound that was coming was enough. And by the time he had grown old enough, so he passed away. And then from that point onwards, the idea shifted to Australia. It was William Clark. William Clark, no? What Clark? William? My first name is? Graham Clark. Graham Clark who picked up the idea. He got the idea sitting on his father was a deaf person, was a shopkeeper, and people used to make masti of him. Always, very unfortunately, blindness is a matter of pity, deafness is a matter of masti, majak. Sala bahira hai, bichara andha hai. It is never the other way around. So his father was made fun of abundantly, and he felt extremely hurt, and he wanted to do something for it, and there was no treatment. Presbyacusis had no treatment. He was hell bent on doing it, and he kept on thinking cochlear implant would be the only idea that would come to it, but there was no way to insert an electrode in the cochlea. He was sitting on a beach. Australia is full of beach all around. He had a shell in his hand, और वहीं पत्ती एक घास की पत्ती थी, वो उठा के उसमें डाल रहा था, ऐसा ही मस्ती कर रहा था. I mean, thinking and putting, and the patti went in, and that suddenly clicked the idea that electrode can also go in the cochlea. That was the beginning or birth of the multi-electrode implant today. Sorry, less of temporal bone. Huh? So now we have done, if you look at facial nerve, you approach the vertical segment or the mustard segment of the facial nerve from behind. There is no other way to approach the facial nerve, vertical segment, except from going from behind. The pyramidal segment you have to necessarily approach from the lateral aspect. You cannot approach pyramidal segment from any other approach. And the tympanic segment you have to necessarily approach inferiorly. So posteriorly, laterally, and inferiorly. You turn around the facial nerve like that. This peculiar way of approaching the facial nerve to decompress the facial nerve is called as बार्बर पोलिंग. मैंने जब पहली बार सुना था, I was completely bold. ये बार्बर कहाँ से आ गया इसमें? So I searched for it, and again another interesting story has come around. तुम अगर हाईवे पे जा रहे हो और तुम्हारा टायर पंक्चर हो गया और तुमको रिपेयर करना है, तो हाउ डू यू नो कि ये टायर वाला है?
टायर लगा हुआ.
हाँ, वो नहीं, ऐसा हीप ऑफ टायर पड़ा होगा दुकान के बाहर. सो यू नो ये टायर वाला है. दैट्स इंडियन वे ऑफ एडवर्टाइजिंग और टेलिंग कि हम टायर वाला है. In US, the barbers put up a pole outside their saloon with a blue and red rings, spiral rings around it. And they are called as barber pole. All US will have barber pole wherever saloons are. Just dukan ke bahar. So that is barber pole, this is barber poling. Funny, but that's how barber comes in. So now I'll be doing barber poling now. ये डायमंड पर देना ना मेरे को. छोटा है क्या तो दे, नहीं है तो ठीक है. नहीं, इतना छोटा नहीं चाहिए. नहीं, नॉट डायमंड. चलो ठीक है, व्हाटएवर इट इज. है नहीं कोई. चलो ठीक है. आई डोंट हैव डायमंड बर. इट डजंट मैटर. आई वांट टू शो यू द प्रिंसिपल, नॉट द फाइननेस ऑफ dissection. फोकस नहीं होता यार. So now I drill the. Now I should be using diamond burr. On the fallopian canal I need to use diamond burr. Now I will have to go, this is posterior, now I cannot go posterior anymore, so I go lateral. Better? Are you in focus? Alright. No, I am not in focus and I cannot be in focus for whatever reason. I am doing it a little partially blind, but it's alright. That is pyramidal process now, and if I continue further, I cannot go laterally any further because lateral is the ossicle. Ji pakad jara. Anyway, I don't think I can proceed because of my little limitations over here, but you can understand that because there are laterally the malleus and incus, I cannot expose the facial laterally. Pyramid I can expose laterally, mustard segment I can expose posteriorly, so the tympanic segment has to be exposed inferiorly. So you turn around and that's called as barber pulling. So posterior tympanotomy, I don't think it takes more than 5-7 minutes. Facial nerve decompression, it doesn't take more than 5-7 minutes. I'll show you another very quick, very fast surgery, and that is, let me first show you episiotomy. Now that is more important. Now episiotomy is another 4-5 minutes, and the safe way of doing it is, क्या प्रॉब्लम है यार, ये लाइट लगा तो है. इधर लगा. Oh wow, good. Yeah, I'm now set. Now we can focus kar, now you can do it. Now I'm focused properly. Right, now you see, you leave behind this little bone, and from this point onwards you go from, I was coming top to medially, yes, because this is a fast way of doing it, or medial to lateral, this is fast way of doing it. But once you come there, then you go from behind forward, keeping all the while under your view the ossicle. एंड टिपिकली जस्ट मेलेस दिख गया कि एटिकोटॉमी हो गया, ऐसा नहीं है. A full eticotomy is you should go up to anterior etic. At no point of time your burr is supposed to touch the ossicle. छोटा सेक्शन है नहीं है सलाइन बस. So now this is complete eticotomy. You can see malleus and you can see space anterior to malleus also. Can you see? No, I heard a no also. Pick that. Pick that. This is incus. હવે સેન્ટરમાં છે. This is incus, this is malioinguinal joint and this is malleus. ફોકસ કરો. થયું? So incus, inguinostapedial joint and malleus. Not inguinostapedial, malioinguinal joint. બરાબર છે? With a little burr I can remove this also, small diamond burr થી. આ કાઢી લે તો it's complete. નહીં એવું લાગે તો છે પણ I don't think so. No. Now sometimes you do come across, rarely, but you do come across a situation where the malleus and incus are fixed in etic. Fortunately, most of the time they are fixed in etic superiorly. Now, if they were to be fixed medially, you can do nothing because you cannot approach the medial aspect of the ossicle keeping the ossicles in position. It's not possible. If you have a situation like that, it's the most, it's like stapedectomy results. All you do is you burr the space between the two, you drill away using a diamond burr and at the expense of the ossicle. So that means you remove the top part of the ossicle of malleus head also and incus body also, and the whole chain becomes loose and permanently loose if you have 1 mm burr going in between the two. And they do extremely well. There are very few fellows who come like that, but they do extremely well because invariably we are sort of a referral center. So घूम-घाम के कभी-कभी patient आया हुआ होता है. So he has undergone stapedotomy twice, attempted stapedotomy twice. It has not worked. And then by the previous experience, I know that there is nothing wrong with the stape, so I have to open the attic. So open the attic, just drill that little away. It's a very simple procedure. This is that, and it works extremely well. I mean, it's like stapedotomy, All right. 1 mm burr is good enough. Point to be taken is at the expense of ossicle. I mean, you may not create a tegment defect. छोटा कोनिकल burr दे दे, वही अभी जो यूज कर रहा था. कोनिकल नहीं, वही जो यूज कर रहा था. This is lateral canal. I am now trying to define posterior canal. And what I am removing is a jali. That means mustard air cells. That means not labyrinth. So, yes. बता दो. Acha na, bone is not conducive. Now you can see the posterior canal. ये बंद हो गया. बड़ा वाला दे दो. हाँ हाँ. You can have two approaches. One through the mastoid. That means you do this cortical mastoidectomy. Defect, make a opening in the tegment close to superior canal. Just lift up the dura and there you are. Or other way around is you directly make a, instead of making a window there, here, and then going above, you make a window here. You make a big slit like opening over here. You need not do a regular posterior fossa, middle fossa approach opening. You don't need such a large opening. You make a slit, use 6 mm burr, that is good enough of an opening. Lift up the dura and there you are. શું કહો છો? Yeah, I am coming to that. Yeah. Again you see a soft, smooth bone coming up, very different in character, just beginning to appear. These are retrolabyrinthine cells. Yeah, retro means behind. I made an opening there in the tegmen. That is superior canal. All right. That is posterior canal. Yes, this one. This is now partially marrow and partially, it's not fully brown. So there is a little bit of marrow in that. As you go, we saw inferiorly that it was all completely brown. So that's your posterior semicircular canal, that's your lateral canal, that's your superior canal. All these things put together is called as solid angle. Alright? Now, if I draw a line along this lateral canal, it will cut the posterior canal halfway down and hit the Trotman's triangle. Now, what is a Trotman's triangle is from here to here is sigmoid sinus, from here to here it's not sigmoid sinus. There is a plate of bone. This plate of bone is called as Trotman's triangle. It is surrounded with superior petrosal sinus above, sigmoid sinus below, sigmoid sinus posteriorly, sigmoid sinus below, and medially posterior canal. In between this, that is superior petrosal sinus, sigmoid sinus, and posterior canal, इसके बीच में का जो triangle है, that is Trotman's triangle. So it will hit this Donaldson's line. If I draw, it will cut this into two and hit over here. If I draw a line along the facial now, it will come here. Now if I bisect this imaginary line and this, इसके बीच में का angle, it will be somewhere there. Over here is your endolymphatic sac. So all I have to do is remove bone over here till I come across dura, and then how do I identify that this is sac and not dura? There are three ways of doing it. One is, if you push dura, it will get lifted off the bone, except at one place. This is defined, definite. I mean, there is no imagination in whatever I am talking. If I push dura, like middle fossa dura from the tegmen, if I push up, it will get lifted out because there are two separate structures. If I push posterior fossa dura, it will get lifted off from the Trotman's triangle, from the Trotman's plate of bone, except at one place. That is a place where the sac becomes duct and enters into the bone. It will not get lifted off from there. So there is always one point where it does not get lifted. From that point onwards, you see a triangular structure which has blood vessels running over it, fanning out from the duct area. It has a different color. And lastly, if you inside that you see glistening white appearance. That is classical of any sac having that endothelium lining. So these three things, different color, will not be lifted out at one point. From that point you will see blood vessels fanning out. That thing will be triangular in shape. As pakka sac. Last proof is incise and see it. Alright? I cannot show you that because of cadaver position. Now I want to take you quickly to jugular fossa, what we were doing yesterday, to show you what we were doing. I know those of you who saw must have seen more blood than anything else. Yesterday was a very different situation where the facial nerve was passing through the tumor. So to save the facial nerve, we had no choice but to cut the tumor. Once you cut glomus, it bleeds. It will not spare you because it's only vessels, large and small, but vessels only. So it was bleeding. Now what we were doing is sometimes I would dissect there, sometime there, was the bleeding was not allowing me to finish at one place. So when it would bleed too much, I'd just put something over there and start drilling somewhere else. Once this starts bleeding, I'll go to third place. And that's how we ultimately removed the entire tumor once, and classical of glomus. Once the tumor comes out, there is no bleeding. That's what you saw yesterday. Yesterday's tumor was also infiltrating into the cochlea, which we knew preoperatively that there will be infiltration. I was expecting it from below, but medially nahi tha, it was from the lateral aspect, and I don't know whether you people saw or understood what was transmitted. I do not know, but we could see the inside of the cochlea after the tumor was removed. So we will go to jugular fossa very quickly now. So I'll be little talking less and drilling more. ત્યાં જવું છે ને સાહેબ? Shall we do that? Story of cochlea. All right. Let me talk about that. You see, there is no nerve, there is no place in the entire body where everything turns at right angle. You see facial nerve turning at right angle means sharp angle, I mean. Facial nerve turning at right angle. Carotid turning at right angle. Jugular bulb becoming jugular vein or jugular sinus. Sigmoid sinus becoming jugular vein at right angle. Stapedius tendon turning at right angle. Tensor tympani turning at right angle. है कोई दूसरी बॉडी में ऐसी जगह जो sharp right angle turn होता है? कहीं भी नहीं है. Now why such a thing happens? Such a thing happens because labyrinth is an organ of balance, and to some extent for hearing also. It's far more important to have balance, and yes, it's good to hear also. Same way as larynx, it's far more important as an air passage, and incidentally you make sound also from it. This balance, organ of balance, will function as an organ of balance only when the balance is fixed. वो balance ही ऐसा हिलता रहा, तराजू हिलता रहा तो balance कैसा करेगा? So it has to be fixed in the base of the brain permanently. वो fix हो जाने के बाद the brain continues to develop. So the facial nerve is originally coming out straight and hitting into the auricular muscles. But then brain develops and takes it backward. Cochlea तो वहीं बैठा हुआ है, वो हिलने वाला नहीं है अभी cochlea and otherwise labyrinth. So you get that turn. निकलने के बाद I told you why बाहर का turn क्यों होता है. Yeah. Then mastoid develops, so it has to take that pyramidal turn. So every turn is explained now. Similarly, the carotid originally goes straight. Because the brain develops into a large structure, it gets pulled behind, and so it develops that right angle, two right angles. This is interesting to know because this is development. ये books में लिखा हुआ है, मेरा invention नहीं है, but पढ़ते नहीं हम लोग या पता नहीं होता है. I mean these points, number of points that I am talking to you are something that are for one or the other reason not discussed, but they are worth knowing about it. इश्क था निकलने से. Now the structures that come in the way, yesterday on the bone we saw, first is the mastoid bone that comes in the mastoid tip. You want to remove mastoid tip. The second thing that comes is the digastric muscle. You want to remove digastric muscle. The third thing that comes in your view is facial nerve from the stylomastoid foramen. You want to get that out. The fourth thing that comes in your way is styloid process. You want to get that out. Once you have removed mastoid, digastric, facial, and styloid, you are on the jugular foramen. All right? अभी हो गया बेटा, जाने दे. चलते मुझे आई विल ऑल्सो डू ट्रांसपोजिशन ऑफ फेशियल नाउ. बड़ा कटिंग कर दे लगा इसको. अभी जो सबसे बड़ा था ना, बड़ा कटिंग ब्रश जो पहले यूज़ कर रहा था. या थैंक यू. बड़ा सेक्शन. All right, now I will do first facial transposition. So for facial transposition, all these things, cortical mastoidectomy, exposure, posterior tympanotomy are fundamental parts. After that, you do all right. Now आमा तो नहीं करता आवड़े because we already done posterior tympanotomy, but we will still show. Now for a good canal wall down, your anterior અહીંયા સુધી, that means atic wall and anterior canal wall should be in one line. There should be nothing coming there. What is called as anterior buttress is not to be present at all. Now this is what bulge is called anterior buttress, this is what is called as posterior buttress. Again as scutum. This little bone is called scutum. Now this scutum basically means outer shell, and that is the outer shell of the atic, and that's why that is called as scutum. Now
Most inferior part of the lateral atic wall.
most inferior, medial ne?
Medial.
Medial most part of the superior canal wall is scutum. So you now this is anterior buttress, this is posterior buttress. Now in anatomy there is no anterior buttress, there is no posterior buttress. I have drilled the bone in such a way that I have created those buttresses. You understand? So anatomy books will never mention anterior buttress and posterior buttress. They are mentioned only in surgical books. Alright, classically the way geniculate ganglion is a subdural structure in all anatomy books. पर हमको तो कान में दिखता है वो, तो ऑटोलॉजिक स्ट्रक्चर है या सबड्यूरल स्ट्रक्चर है? कौन बोली, बोलो पाछो. यू सेड फेशियल ब्रिज बताड़ू एम या सो नहीं हमें बताता तो नहीं आवड़े, पर यू सी बेसिकली बिकॉज वी ऑलरेडी डन पोस्टीरियर टिम्पैनोटॉमी. Whatever this bone, if posterior tympanotomy was not done, would be called as a facial bridge or facial ridge. Ridge. This is facial ridge, and this is bridge. This is bridge of bone. This is ridge of bone. All right. Ridge because under that there is some structure. Bridge because under that there is no structure. No structure means it's dissociated from malleus incus. So that's why that's called. Polo?
Adidas is there. There is a underway. The bone which is lying, the posterior canal wall bone which is lying over the adidas is the ridge.
Ah, that's edge. That's what I'm saying. So this is anterior buttress, posterior buttress, and you don't want that to be kept. छोटा बर भी दे देना मेरे को. कटिंग छोटा. ये पिक किया समथिंग, सम इंस्ट्रूमेंट. There is the scutum that I am removing now. This is classical anterior bridge, frequently left like that by many surgeons. Now a good, क्या हो गया है, बर रेडी दे दो मेरे हाथ में. या थैंक यू सो मच. या छोटा देना इससे भी. हाफ दिस साइड. या थैंक यू. You see now the anterior wall, anterior canal wall is in one line. The anterior mastoid wall is not in one line because there is a bump over here. बड़ा canal. Now to make this bump go, I should drill the inferior canal wall here so that this bump will go. These are all Sharpie's fibers. Can you see them? Multiple of them. Now, can you appreciate that the mastoid tip, inferior canal wall, anterior canal wall, and anterior atic wall is in one line? This is what you should achieve in an ideal cavity. There are no bumps anywhere. The only bump that you see is a mild bump of facial nerve. Otherwise, or lateral canal. Otherwise, you see no bumps. All right? All right. Now, with that, I will remove the ossicles for the. ये मुझे कुछ देना है, पिक देना. थोड़ा स्ट्रॉन्गर इंस्ट्रूमेंट है तो अच्छा रहेगा. सिकल जैसा कुछ है तो अच्छा. कुछ भी दूसरा कुछ भी चलेगा. ले ले. Now we have exposed all this facial. You can see that छोटा डायमंड नहीं होगा ड्रिल, जो डायमंड है वो तो अभी आया ना. नहीं डाला पानी. या थैंक यू सो मच. Now fortunately this particular bone is very thin, so it gets easily decompression done very easily. चलो मुझे बड़ा को निकल दो. बड़ा को निकलने, बड़ा बड़ा वो वही जो कटिंग है. Alright, so first thing I'm getting out of my way is mustard tip.
Yes, sir.
इसको पकड़ के रखो सेंटर में. You can see these fibers here also.
Yes, sir.
ये चलता नहीं है.
See the facial now, lowest part of the facial.
Suction,
now.
suction. If you have blade, just cut this off. Now I am removing the inferior canal wall.
Yes, sir.
What is it? चलता नहीं, सेक्शन नहीं चलता है. In the tympanic bone is a peculiar bone. It has a C-shaped which converts, which meets the squamous part of the temporal bone and makes it into an O or a complete ring. But inferior to that runs a vertical ridge, which is called as the vaginal process of the tympanic bone. Medial to that runs the styloid. The medial end of the vaginal process runs the styloid. Between that is a small gap, and which is sheath. Vagina basically would mean sheath. Sheath, म्यान, तलवार का म्यान होता है वैसा. The sheath is called vagina, and that is why that is called as a vaginal process. I mean, I wonder why it was called vaginal process, but that is what it is. All right. ये मिला क्या? ब्लेड है क्या? ब्लेड है तो दो. Forceps. This is nothing else but parts of digastric muscle, and this is the sleeve of stylomastoid foramen. It's always very tough, very dense, very difficult to go around. You have to be careful because it is tough. Inside it is a very delicate structure which you want to protect at any cost. Bone है अभी भी. ड्रिल दे मेरे को.
Outside lunch, Daddy, we can proceed after the.
All right, all right. कितना वाग्या करे? How much? पौना बे? Oopsie. पंद्रह. So you make a cut here like that. This is the fiber that I am talking about. Along inside that is your facial nerve safely protected as long as you don't go. You remain near the bone and not near the nerve. There are dense fibers attached to periosteum and peridurium. In the mastoid segment, in the tympanic segment, no fibers. I think I said this yesterday also. That is the nerve to stapedius muscle over here. Can you see that? दिखेगा अभी थोड़ी देर में. That whitish thing. You normally don't see that because that nerve arises from the medial aspect of the facial nerve. You never hold the nerve the way I am holding it in life. This is what you are supposed to hold, not the nerve. P knife. P knife. जो भी है, side knife, whatever you have. Knife. Blade 15. P. P. Side knife. This comes out quite easily. Alright, now you take this facial nerve and put it on the intake canal wall, or rather anti-aortic wall, and from there it goes. So now you have got the second thing out, the third thing out rather. You got the mastoid out, you got the digastric out, now you got the facial out. This is what I was doing was facial transposition. This is called as anterior transposition. There are some procedures in which you do posterior transposition. We are not talking of that just now. But that's why, because there are two transpositions, it is named anterior and posterior. Now there is nothing over here except the styloid process. This is vaginal process of सक्शन चलता नहीं है, बंद करो. this is what you are trying to protect all this time. Because of facial, now there is no facial, and because there is no facial, there are no structures over here. Suction. बंद हो गया. There are only two structures that I am bothered about now. Superiorly, one is cochlea, the other is posterior, ampullary end of posterior canal. These are the only two structures superiorly that I am supposed to protect. Otherwise, I will continue drilling medially and I will hit the lateral part of the jugular foramen. So suddenly you see my drilling very different. This drilling changes based on your knowledge of anatomy. You know there is no structure, so why be slow over there? That's your jugular bulb. Terminal part of sigmoid sign. That's your posterior canal wall ampullary end, isn't it? That's what I'm trying to protect. So superiorly I can't go beyond that point. Anteriorly, that is a round window over here. Can you see a bit of it here? And the cochlea. These are infracochlear air cell tract. Give me. Now that is the blood within the jugular bulb, and you see some opening there, some black dot. That is what? Sickle then either. I hope this is sickle. Sickle, give me sickle. This black dot is an opening. Can you see that? ये क्या है? कोई भी बता सकता है? This is the jugular bulb, and this is sigmoid sinus, which are partially open. So the shape of sigmoid sinus is from here to here to here. So it is not. Is it not S shaped? ये ऐसा शेप का है, देखो 1, 2 and 3. Yeah. Sigma means S. The Roman word sigma is S, and it looks like S, so sigmoid. All right. Anything that looks like something is oid. Spheroid, circuloid, ovoid, and on and on. Now that is the inferior petrosal sinus opening into jugular bulb. Now during live surgery, if you are doing glomus, immediately on the medial wall of this, which is adherent to the bone, the medial wall of the jugular bulb is adherent to the bone, are the nerves. The jugular foramen has two compartments, the neural compartment and the vascular compartment. Immediately medial is the neural compartment. The bleeding occurs from, तुमने sigmoid बंद कर दिया है, jugular बंद कर दिया है, फिर bleeding कहाँ से होता है? वो bleeding यहाँ से होता है. This you cannot control. There is no way to control the inferior petrosal vein bleeding. There are two veins actually that bleeds. One is inferior petrosal vein and the other is occipital vein. And both veins come from medially and open into the jugular bulb. So there is no way to ligate them, catch them. There is no way. So all you do is you remove the tumor. Fortunately, the tumor is always arising from the superior aspect of the jugular bulb. So when you remove that, the superior aspect comes out, the medial aspect tears and remains stuck. And you put gel foam over there or Surgicel or whatever, and because it's a low pressure bleed, it always stops. So when you are doing a jugular tumor, glomus tumor, the way to do it is you go around the tumor, expose the tumor completely. Don't touch the tumor, like all tumors. Don't touch the tumor till you've gone all around it. You've created enough space. And then once you have done that, then directly jump onto it and very rapidly remove it. And that's what we were trying to do yesterday. We could not for a reason I just told you. But towards the end, we packed that jugular bulb. I don't know how many of you realized, but we packed it because of these veins. Lunch is ready, I am told. So I think we should eat. Do you think the same way as I think? It's good. Haji?
Sir, this lunch ka ye
हाँ, please, madam, you do it. You do the lunch announcements. APs, you don't come into these situations. But if you do larger surgeries, larger would mean anything like petrous apex or glomus or whatever you are doing. The brain or the dura is separated from external auditory canal by two plates of bone, either sigmoid or Trotman's triangle or tegmen as one plate of bone, middle fossa or posterior fossa, and the other is external auditory canal. Now, for a surgery in which you remove external auditory canal, that means open cavity, you must see that you preserve these two plates of bones. If you remove both the plates of bone, the dura will be definitely seen in the external auditory canal, for sure. For sure. If the opening into this plate is more than 10 mm, it is 100%. Less than 10 mm, 8 to 10 mm may not happen. Less than 8 mm, body takes care of it. So keep it in mind that the external canal is separated from dura by two plates of bones. You cannot afford to destroy both plates of bones. Just I thought I should share with you. So whenever you are doing a canal wall down, your plates should be preserved. I said one thing, that if you have a very low dura, almost the single plate, sometimes the sigmoid is so far forward that under the cortex is sigmoid. I have had situation as a junior, once I started, and there was blood about which I cannot describe. And as a junior you get completely baffled, क्या हो गया? ऐसा तो कभी होता नहीं है. ऐसा जनरली नहीं होता है, लेकिन नहीं हो सकता ऐसा नहीं है. Fortunately nowadays you have CT scan, so you know beforehand where is sigmoid. And whenever you are doing any mustard surgery or planning to drill, always have one eye on sigmoid. कितना दूर है? You immediately know. I mean, there is no rocket science about it. Sometimes we remain so focused on the disease, like suppose if I am looking for schwannoma, I am so focused on schwannoma I forget sigmoid sinus, and then later on realize, oh my god, sigmoid is so far forward that I can't enter the mustard also. So be aware about it. Now suppose you are doing a cochlear implantation and you have a sigmoid which is so far forward and you do not want to disturb posterior canal wall and you don't want to do an open cavity also, then how will you proceed? Open cavity करने के लिए ठीक है, inside out किया तो open cavity हो जाता है. But here is a situation you don't want to remove the posterior canal wall, you don't want to do open cavity, and yet you want to do a posterior tympanotomy. Any ideas, anybody?
Think of floating island of bone over the sigmoid sinus and press it posterior.
Expose the sigmoid sinus, expose the dura, and then press it backwards or superiorly. Do your work and leave it. It will come back in its position. Your canal is still protecting the dura from coming inside the canal. Now these are odd situations that you do come across in real life, and then you are completely baffled what to do. But these are the answers that over a period of time people have found out, and they work very well. Yeah?
Your golden pearls and tips for tympanoplasty, about canalplasty. You beautifully put your Mercedes-Benz type of stuff, endometer, which I will never in my life. Bony canal, how it helps drilling and making it cylindrical to under there or
Yeah, I mean,
canalplasty, importance of canal.
what sir is saying is simple, that the canal should be shaped in such a way that you should be able to see each and every part of the drum. There is a school of thought, particularly European school of thought, and see, whatever is European and American is international, whatever Indian is Indian. ऐसा कुछ भी नहीं है, ऐसा उन लोगों ने किया है. Even Indians are international. That is what you should know and you should believe, because we are not gadhas. I mean, जो भी कुछ हुआ, it's their viewpoint which makes it like that. In any case, with this little background, the European school of thought is each and every corner of drum should be seen. As I personally don't believe and I don't do it. कुछ part of the drum नहीं दिखा तो कौन देखता, कौन अंदर जाके? If there is no trouble, who is going to see inside? और अंदर देखता भी है तो हम लोग देखते हैं. So if there is no problem, then why try to make it in such a way that वो दिखे? ज़रूरी नहीं है उसको दिखना. फिर भी the European school of thought is that each part of the drum is to be seen, because then when the patient comes for re-examination, you are examining the ear, putting in the speculum, does not touch the bone and does not give rise to pain. So what they do is a lot of surgeon would take a 360-degree cut around the cuff of the canal, that is on the canal, and remove the entire deep canal skin along with the drum, and then keep on drilling all around till the whole thing becomes straight cylinder. Do tympanoplasty, put graft, whatever you want to put, and put the skin cuff back in place. That works well. I mean, the results of tympanoplasty are good. But as I told you that it's a belief that you should be able to see the entire canal. I frequently say that नाक में अंदर का हड्डी टेढ़ा है, क्या फर्क पड़ता है? If the patient is breathing well, अंदर जाके देखता कौन है तेरे मेरे सिवा? तो नहीं जाओ अंदर, मत देखो. क्या फर्क पड़ता है? अंदर से नाक टेढ़ा है. So there are lots of things like that which really does not need treatment. It's the surgeon's mind which behaves like that. I mean, is this what you were asking? And I mean, maybe I have not answered the way.
Pros and cons of both. To make an entire skin tunnel so that the entire margin of the perforation I can cut in the
Yeah. All right. That you.
and see
Yeah.
hump or bump or
Yeah. All right. Now.
the disadvantage also, then the canal skin cuff will not fit the larger body canal. And I have to put a horizontal incision, long axis of the canal.
Huh.
This is the disadvantage of making a wide body canal.
Right. Now. You see, if you have a small canal, the skin cuff will be small. If you make it wide, you cannot make your cuff wide. So now you are falling short of skin, which is not good because it heals with granulation. And granulation may end up into fibrosis. So you may get fibrotic canal lining. Huh. So as a shoot off for that, there are some people who put skin graft, partial thickness skin graft. But I mean, these are ways of doing things. I personally don't subscribe to that. That's personal. It is not international. It is not something universally accepted. That's my belief. Now tell me something, If you are not asking me, I am asking you. So you are leading yourself into danger now. We have 5 sensory organs. Of the 5, 4 are in head. The 5th is all over, touch and temperature. Why are they in head? I mean, I have frequently wondered कि मेरी आँख इधर होती तो ये क्या कर रहा है, इधर से दिखता था, ऊपर से ऐसा हाथ किया तो ऊपर से दिखता था मुझे. Head पे है तो I can't take my head over there. So it's a distinct disadvantage of eye not on the tip of my finger. नहीं तो वो भगवान ने इधर इतना अच्छा अच्छा बनाया तो उधर भी बना सकता था ना. All right, so one is injury, fine. Huh?
The limbs are appendages for the organism to survive. Organism is to explore for food, nutrition, and propagate. So वो सब एक जगह पर है. After seeing the tentacles can extend and grab hold of the food or whatever.
अपन उस पे टेंटिकल पे ही आँख होती तो वहीं जाके पकड़ भी लेता था, सब कुछ कर सकता था.
Double ending circle.
I'll tell you the answer. I'll tell you the genuine scientific answer. It's something which has bothered me. कि ऐसा क्यों है? And when I got the correct answer, it settled down. The correct answer is because these are organs of survival. I ought to know कि शेर आ रहा है सामने से. I ought to know कि पीछे कुछ बॉम्ब फटा है. Yeah, whatever, I mean, some sound, some smell, something should tell me. And the faster it reaches from the sensory organ to my brain, the better my survival rate is. It is in microseconds. You might have seen a frog trying to catch an insect, and that insect goes off from the tongue of the frog, is in microseconds. So it is those microseconds that matter. So the nerves have to be shortest. So all the 4 nerves are the shortest possible nerve, in which the shortest is olfactory nerve. Because we have become humans, we are odd bit species, the rest are not, the rest survive on their noses. We don't survive on our noses. All right. Now, another question. And I'm asking you this question because I have a reason to ask you this, कि कभी तुम भी ऐसा सोचो और उसका जवाब ढूंढ के निकालो. निकलता है, कहीं ना कहीं से मिल जाता है जवाब. दोनों आंखें से सामने दी है, दोनों कान क्यों सामने नहीं दिए? ये ऐसा वाई दिस अजीब सॉर्ट ऑफ एनाटॉमी, दोनों आंखें सामने, दोनों कान इधर उधर. एक आंख इधर और 2 कान सामने होते तो क्या होता था?
Difference in the sound perception, the millisecond, microseconds, it helps localization of the source of the sound.
हाँ, so
So we can be aware of the
નહીં, પણ અહીંયાથી બંને કાનમાં સામનેથી આવે તો ન સમજ પડે?
તો remain difference ઓછો, જેટલો વધારે એટલો સારું. Interaural.
Also there is another question I want to ask. कान इतना अंदर क्यों है? Why is cochlea so deep inside?
I think that's stimulated by fluid. We were basically from aquatic.
नहीं, अंदर क्यों, इतना अंदर क्यों घुसड़ के रखा है? सर ऊपर ऊपर होता तो सब सर्जरी कर सकते थे ना आराम से. I'll tell you the answer and think about it. Think of the answer. The answer may be wrong and I want you to correct the answer. You see, if I want to see an object with 2 eyes, they have to be at a slightly different angle, not grossly different angle. If the 2 eyes are like that, they will not see the same image. I want to see the same image, so they have to come like that. But I have to see them at an angle. Then only I can get 3 dimension. So eyes cannot be like that. The birds and all those animals, the frog and etc., all those animals who have eyes like that, they do not have binocular vision. But they don't need binocular vision. They are more interested in knowing कौन हमको खाने के लिए आ रहा है. I mean, am I pray for something or am I going to pray something? So they don't need 3-dimensional vision. We need 3-dimensional vision, so the eyes have to come like that. And that's how you get the 2 eyes like that. तो कान क्यों ऐसे रखे हैं? Now कान इसलिए रखे हैं कि because the sound is low frequency and big wavelength. So if I have to hear sounds from stereoscopic sound, that means आवाज यहाँ से आ रही है कि यहाँ से आ रही है, you know what is the, at what angle I can differentiate कि 2 अलग अलग जगह से sound आ रही है? Do you know that angle? You should know because this is basic. Huh. Yeah. So what now? The second question was, then she's answering. She's thinking about the first question. You are talking about the second question. The angle is 3 degrees. If 2 sounds come at an angle of 3 degrees, you can make out कि दोनों अलग अलग जगह से sound आ रहा है. You should know this. Now, that is one part. How do you know? You know it because the ears are so deep inside. Now, what does it matter or how does it matter is because one, I have an effect of my head shadow. अगर यहाँ से साउंड आ रही है तो पहले ये कान पे आएगी, उसके कुछ माइक्रो सेकंड के बाद यहाँ आएगी. सो देयर इज अ शेडो ऑफ माय ओन हेड फॉलिंग ऑन द अदर ईयर. दैट्स वन पार्ट. द अदर पार्ट इज इट इज सो डीप इनसाइड दैट ये साउंड को ऐसा उल्टा आने के लिए फर्दर देर लगती है, माइक्रो सेकंड्स अगेन. एंड दैट इज व्हाट गिव्स राइज टू 3-dimensional hearing, just because they are so deeply seated. ये तो नहीं होता था. तुम लोग you will not be able to hear the sound कहाँ से आ रहा है. Another very peculiar and interesting thing about sound is sound, you need not turn your head anywhere. मुझे कुछ देखने के लिए उसके सामने देखना पड़ता है. साउंड को सुनने के लिए मुझे सिर नहीं घुमाना पड़ता है. मुझे यहीं खड़ा हूं, मुझे मालूम है कौन सी डायरेक्शन से आ रहा है, टू कितनी दूर से आ रहा है. जस्ट इमेजिन, वो खाना बनाने वाली लेडी ने उसका कुछ बर्तन गिरा दिया. ऑल ऑफ यू वुड नो वो बर्तन गिरा है, कहाँ गिरा है, कितनी दूर गिरा है, कौन सा बर्तन गिरा है. थाली गिरी है या कप गिरा है या कांच का कप था जो गिर के फूट गया. हाउ डू यू नो ऑल दिस? आई मीन इट इज सच अ वंडर ऑफ नेचर दैट यू टेक इट सो मच फॉर ग्रांटेड कि तो होता ही है, तो आप सबको मालूम है, मुझे भी मालूम है. But it's a great wonder of nature that you know this, and this is all because of shadows of sounds falling on both the ears at different microseconds के अंदर, different time frames के अंदर, and the brain is able to catch both the sounds, fuse them and tell you कि वहाँ से गिरा है. The rest is brain, the rest is computing. So think about it. Now, another question. This is the smell of lemon, or this is mango, or this is pineapple. Sweet है. तुम्हारी आंख बंद करके तुमको मैंगो खिलाया या पाइनएप्पल खिलाया, दोनों स्वीट है. हाउ डू यू नो ये मैंगो और ये पाइनएप्पल है? दोनों स्वीट है. My other way around, my next question is, think about it, just think of whatever I am asking you. I want you to think. The nose is a chemical sensation. The mouth or the taste is chemical sensation. ये दोनों chemical sensation को इतने पास पास में क्यों रखा है? That is where the answer lies. How do you recognize pineapple from mango with your closed eyes? From the smell. So now, you can never taste something alone. You can never smell something alone. You can smell from a distance, but when you are eating, you get both the taste and the smell, and together they are called as, there's a nice word in English, aroma or flavor. Aroma is smell. So flavor is taste and smell put together, and both are chemical in nature, and that's why you can make out pineapple from apple or mango. You are dealing with sensory organs, isn't it? So थोड़ा सोचो. Thank you, Ardo. Tips नहीं आप ये?
Why nature has made this facial nerve so complex? Basically, it is muscular for expression. God has given it taste का भी temporary उसको लेकर जाते हैं because you think so deeply. Taste का special sensation motor nerve के अंदर से जाता है. Genicular ganglion gate.
No, I mean that is miserable for ENT surgeons, you know. હું તો ભગવાનને જઈને બે સવાલ તો સ્ટ્રેટ પૂછવાનો છે. એક તો ફેશિયલ ના હોય અહીંયા કેમ મૂકી છે, અને બીજું બંને કાન આમ અલગ અલગ કેમ રાખ્યા છે? પેલો મારો પેશન્ટ માથું જ નથી ફરાવતો આમ. Now, I'll tell you last. I mean, it's partially answers sir's question. I cannot tell you how to be a good resident because I was a terrible resident. So that's the reason why I said I'm happy you are not asking my teacher or in front of my teacher to talk about good resident. And think about it, and I really mean each word I'm talking. You ought to have passion for something. whatever you are doing, you do it passionately. You do it with great love. चोरी करना है ना तो इस तरह से चोरी करो कि पुलिस वाला साला पागल हो जाए कि किसने चोरी किया है. वो कितना अमाउंट का है इज लेस इंपॉर्टेंट. द आर्ट ऑफ डूइंग चोरी, आई एम टॉकिंग ऑफ समथिंग बैड, बट उसमें वो आर्ट होना चाहिए, वो कला तुम्हारी होनी चाहिए कि आई रिमेंबर वन मूवी विच इम्प्रेस्ड मी अ लॉट. एक आदमी चोर होता है जो चोरी करता है, और चोरी करने के बाद वो दीवार तोड़ता है, दीवार तोड़ने के बाद चोरी करता है, चोरी करने के बाद उसकी खिड़की बराबर से बना के जाता है, जहाँ तोड़ा हुआ होता है वहाँ खिड़की बना देता है वो, बट ही डज इट वेरी प्रॉपरली एंड गोज. पुलिस वाला आता है, बॉट ढूंढता है, कुछ समझ में नहीं आता है, एंड द अदर पुलिस वाला कम्स एंड सेज कि इफ ही हैज डन इट लाइक दिस, दिस फेलो इज अ पैशनेट आर्टिस्ट, लुक फॉर ऑल द आर्टिस्ट्स, एंड देन दे अल्टीमेटली डिस्कवर. सो उसका वो पैशन था. So you do whatever you are doing. If you are not interested in ENT, don't do ENT. Believe me, don't do ENT. अभी भी टाइम है, छोड़ दो उसको. बट करना है तो उस पैशन से करो कि life then becomes meaningful to you. Life becomes meaningful to others. चोरी करो ये नहीं कह रहा हूँ मैं, लेकिन चोरी करना है तो उस तरह से करो. And try to do pro-social things, not anti-social things, because तुम्हारा pro-social things will help society. So society के लिए जो सही है वो काम करो और उस पैशन से करो. पैसा आता रहता है. Believe me, earning money is the simplest thing. Very very crudely put, prostitute भी पैसा कमाती है, लेकिन पैसा कमाना बड़ी बात नहीं है. काम जो तुम करते हो उस तरह का करो, वो क्वालिटी का करो कि किसी को फायदा हो जाए उससे. डू इट दैट वे. लिसन टू व्हाट आई एम टॉकिंग. थिंक अबाउट इट. डू इट. इट विल मेक अ वाइड डिफरेंस इन योर लाइफ. I remember I took ENT because I saw, I'll tell you a story in a little bit of detail. I did my anatomy. वहाँ कोई नर्व नहीं दिखता था. साइटिक छोड़ के एक नर्व नहीं दिखा मुझे. I got very frustrated कि क्या कुछ दिखता नहीं. And I was always सर्जरी में दिखता है या नहीं दिखता है, सर्जरी में दिखता है या नहीं दिखता है. Anatomy पास हो गया. Now I was putting on that stethoscope and going to the ward. Now I had become a doctor. Like सर्जरी का पोस्टिंग हुआ, अंदर गया, हर्निया कर रहा था. मैं देखते देखते मैं बोला इंग्वाइनल नर्व दिखाओ ना. तो that fellow must not be a very senior person, whomever I was asking to. That was the first time I had entered the surgery hall. He looked for here and then, नहीं 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 बंद करो इसको, कुछ नहीं, कोई नर्व नहीं दिखाने का है. मैं बोला क्या फ़र्क पड़ता है, उधर ही तो इंग्वाइनल नर्व होता है. I was very, मैंने विदाउट एनी इल मीनिंग आई वाज सेइंग कि वहीं तो होता है, दिखा दो ना. ही क्लोज डाउन दैट. उसके 2 महीने के बाद में वन ऑफ माई कजिन अंडरवेंट स्टेपिडेक्टोमी. अंकलेश्वर ऐसा रहता. ही वुड नो इट, सो आई एम पॉइंटिंग आउट. यू मे ऑल्सो नो हु इज अंकलेश्वर. ही इज नो मोर. सोफी तने खबर છે સર ગુજરી ગયા. So Ankleshwar sir was doing stapedectomy in a private clinic. Now I was second year student. मैं पूछा अंदर आऊँ क्या. मैं बोला आजा. सर बोले आजा. Not only he allowed me to come inside, but he took the incision, he reflected the flap, he separated the chorda and he said, now look inside. वो दोरे जैसा क्या दिखता है. तो बोलता है वो chorda tympani now है. And I kept on looking at it like that as if I had seen some treasure in my life, And I said कि साला वो inguinal nerve नहीं दिखता है, वो इतना बड़ा होता है, और ये इतना छोटा nerve इतना clearly कैसे दिखता है. मैं ऑटोलॉजी करूँगा. I got fixated on otology that day. Believe me, this is true story that I am talking. And I have remained fixated on that. It has so happened that even during my studentship, I was called as an otologist. When I was doing my first year residency, second year residency, I knew so little about laryngology and rhinology, but otology में सब कुछ मालूम रहता था. That is what is passion. I was driven by passion for otology. And I have been fairly successful. I am successful not because of anything else, but because of my passion. I'll give you another example. M.B. Agrawal, कितने लोगों ने नाम सुना है? M.B. Agrawal is the hematologist of the country. He was 2 years my senior in the same college. He passed with the highest possible marks in medicine. So he could almost choose any branch he wanted. He chose pathology. So everybody called him, "तू क्या पागल हो गया है क्या? तेरे को समझ नहीं है क्या? तेरे को अक्ल नहीं है क्या?" मुझे पैथोलॉजी करना है, तुमको जो करना है तुम करो. नहीं, तू फर्स्ट आया है, मुझे मालूम है मैं फर्स्ट आया हूँ, मैं पैथोलॉजी करूँगा. I mean, I know it because we were second MBBS students and third MBBS students, so we used to hear stories कि वो एक पागल है, ऐसा करता है. He did his pathology. After doing his pathology, he wanted to do hematology. Again, the branch that was never talked about, was non-existent. He wanted to do hematology. He did hematology. तभी यहाँ नहीं था, it was only in abroad that there was a branch called hematology. He did it. He came back and started practicing, and today he is the final word. He is a world authority. Again, that was his passion. He was passionate to do hematology right at that MBBS level. You need not be passionate about something at MBBS level. It's not that, but he was. So all that I'm trying to tell you is be passionate. Have some passion. Have some passion. वो कुछ भी हो. As I'm telling you, if the passion is pro-social, it's very good. Anti-socials are not good. Thank you very much, everybody. I enjoyed your company. I hope you enjoyed my company. Thank you.